everybody. And in this, the third season of the AOCN Web Academy lectures, we have a very exciting presentation here today, one of the topics which we haven't discussed so far. And before I introduce the speaker, I will introduce our eminent chairperson. Dr. Narayan Saha, sir, is a very senior professor and head of pediatric neurology at National Institute of Neurosciences, Dhaka. He has a lot of experience in pediatric neurological disorders, especially cerebral palsy, and he runs a botulinum toxin clinic there. We are very happy to have him here. And our speaker for today is a young pediatric neurologist, young, very energetic, enthusiastic pediatric neurologist from Chicago. He trained in the Ann and Robert Lurie Children's Hospital at Chicago, and not only pediatric neurology, he's done a fellowship in pediatric neurocritical care. And that's one of the topics that we're going to be discussing today. But not just neurocritical care, his other interest is neurology of mitochondrial diseases. And maybe sometime, another time we'll hear him on mitochondrial diseases as well. So topic for today, I will hand over to Dr. Saha to just little introduce about the topic for today, and then we'll start the session. Sir? Hello?
Yeah. Thanks, Dr. Subhashini Sharma.
Yes.
Thanks, and is it okay?
So there's I think internet connection, it's going a little slow at your end.
Am I audible?
Yes, you're audible. You're audible. You're audible, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Okay. Thank you, Dr. Subhashini Sharma. Actually, thanks and welcome to everybody for attending the webinar. Actually, I am really thankful to Dr. Mithal ma'am, the President AOCN, and to Dr. Subhashini Sharma, Secretary AOCN, and the other executive body members for inviting me to chair this session. Actually, the academic activities of AOCN just cross the geographical boundary of India. Moreover, it has spread over to other parts of the Asia as well as the Asia Pacific region. Actually, we are proud for this events and activities. Really, we should uphold these activities for the betterment of the practicing clinicians in this region. And moreover, in this part of the world, malnutrition is a major problem which adversely affects the brain development and ultimately, especially the cognition and emotional aspects of these activities of development. If there is any superadded brain injury from critical illness, that will further aggravate the situations. So I think we have a renowned speaker today who will talk much about how we can protect the brain from critical injury. If we could extrapolate his experience and knowledge and to scale up the activities in our region, probably we'll be able to minimize the brain injury for the children of this region. Now, may I request Subhashini Sharma to make a brief introduction about the speaker and to start the webinar series. Thank you all.
Yes, sir. Yes, sir. Yes, sir. So we over to Divakar now. He'll be talking about protecting the brain in critically ill children. Divakar, I think you share your screen now.
Sure.
Welcome to our AOCN session.
Thank you. Hello, everybody. I am just going to orient myself for a moment here so I can see you. Okay. So thank you very much, Dr. Subhashini and Dr. Narayan, for having me here today. I've been watching some of these webinars from in Chicago, in my office here in Chicago, and they're fantastic. And I'm very pleased to be a part of this. I think there's a couple of things I want to just introduce right off the bat, and I'll be happy to take questions at the end. I did, in fact, do a Pediatric Neurocritical Care Fellowship here at Lurie Children's Hospital. We have an approach to this that is unique and allows us to train people, which is that we have a number of people that are dedicated exclusively to neurocritical care. And I'll talk more about why we call ourselves a dedicated group and how we approach that. But what I've tried to do in the talk today is make a broader conversation about how these principles that we employ here in our resource-rich environment with a lot of dedicated practitioners can be more broadly applicable, and what the principles are behind what we do. Because honestly, and I really truly mean this, despite the extra training and everything else, I think a lot of this comes down to rational thought and being aware of certain principles in the moment. And I really believe any practitioner can apply these things. And a lot of it comes down to collaborative work with neurosurgery, ICU, other entities that are operating in a very acute setting. So I think once we talk about some of these things, perhaps, hopefully, those concepts will come out. And I will share with you some very specific algorithms we have at our institution that I don't think are generalizable, but they will give you, I'll talk you through how we try to structure acute critical care. So I'm going to start talking here. I will take questions at the end. I think that'll probably be the smoothest way to make sure that I can address questions. But if anything is unclear or if I cut out, please somebody stop me and let me know. Okay. So the agenda today, we'll talk a little bit about the background. We'll talk a little bit about the first principles of neurocritical care as I see them. We'll talk about neuroprotection and neuromonitoring, which are the sort of the mainstay of neurocritical care. And I also want to address long-term concerns, because I think one of the values we have as neurologists is that we tend to follow patients over a longer period of time than our colleagues that manage the acute setting. And so we can think about these patients both in terms of what we do immediately and also how that might impact them in the long term. So what is pediatric neurocritical care? The very first and sort of central concept here is that neurocritical care is really about the practice of neurology in the critical care setting. Now, that may seem obvious from the statement that we've made earlier, but I think if you look at how neurology is practiced in general, there's a lot of emphasis placed on follow-up, on allowing sort of disease to take its course, for diagnostic workups that can take a long time or be quite resource heavy. So really what we're talking about is being available at the bedside for the teams that are taking care of these children acutely. Urgency, as in you're not just available, but you're available on demand. And expediency, meaning once you have become available, you work with the team in real time. You don't just disappear off into the office or back to the neurology service or whatever. That really the purpose of neurocritical care is to aid and support active management in real time as much as possible. You know, one of the things we talk a lot about is that, you know, neurocritical care can affect children that have an underlying neurologic disease. So I think, you know, often we have children that come in with a genetic epilepsy, that come in with status epilepticus, but really a lot of these conditions are affected sort of secondarily by, as Dr. Narayan mentioned, nutritional deficiencies are more common elsewhere in the world, but here we might have children who present with sepsis or have a cardiorespiratory arrest after having an asthmatic attack. And so in these situations, the primary concern is not necessarily the brain, and our job is to make it the primary concern of somebody, and that somebody is us. So there's a real true collaborative spirit in all of these situations where there may be other people managing components of the child's care, but we ourselves are deeply involved in the management of protecting the brain and treating any neurologic symptoms that may arise. But one thing that we've come to appreciate, and I don't know it's going to be different everywhere, but I think it's an important lesson we've learned, is that we're often not the primary caregiver. And even though we view the brain as a central and critical organ, everyone does, our decision-making may not match up with that of the other providers in the moment. So having some sense of that teamwork, of finding a communication skill set that allows you to share your concerns in the model that's being practiced in the moment. So if there are people who are actively doing chest compressions and trying to maintain an airway, you know, it's not necessarily the best time to be pontificating about the possibility of subclinical seizures, but it's something that if you wait and are patient, they will be ready to hear it in the right moment. So developing that rapport is really important. And it's almost as important as having clinical knowledge. I think a lot of what I'm going to tell you is that the clinical knowledge is not rocket science, but it is important to communicate what you think. And then the other thing that really is important here is that most of what we do in neurocritical care is derived from adult neurocritical care. In the United States, adult neurocritical care is an explosive field. There are many, many people around the country that are practicing it. The national boards are now providing board certification for neurocritical care specifically. The fellowships are full. Everybody loves to do this stuff. And there are subspecializations for vascular, stroke-related stuff, people that study sepsis. There's all kinds of things going on. And they, of course, have the power of numbers. So their studies are much more structured and they have data to support things. For children, we're not so lucky, or unlucky, I guess. We don't have as many children that enter into the ICU with neurologic concerns, and we don't have standalone units specifically for neurocritical care. One of the big realizations that I had along the way was that in the adult world, there are many, many, many patients that are intubated essentially for mental status purposes. And when they're in the ICU, you extubate them, for mental status purposes. And I knew that, but I didn't really think much about it. In the pediatric world, intubation is driven in large part by lung pathology or by protecting the airway for other reasons. And there are plenty of patients who are intubated because of concerns about mental status, but we don't typically think of those patients as our own. So I think one of the values that we have brought in is that there's many situations where respiratory support or other medical support can actually be modified based on a neurologic evaluation. And that's something we derive from the adult population. And then, so what we try to do is take best practices from the adult world and then apply them into the pediatric world as best as possible. And a lot of it is scientific reasoning. It's not based on data from the pediatric world, which has its own problems. There's no question about that. And one of our goals in a research-rich environment like our own is to document what we do and try to publish it over time. And we have a number of colleagues, and I'll share some of our work and their work over the course of this talk. So what are the first principles of neurocritical care? Well, I think these are things everyone will agree on. The brain cannot survive without circulation, airway, and breathing. Those are the first principles of critical care medicine, of all medicine really, and it does not change for neurocritical care. Brain injuries are time sensitive. So many people have heard the term time equals brain. This is something that the stroke literature started pushing many years ago in the adult world, and I don't see why it's any different for anyone else. I think there's a false sense of security for children, that children have more plastic brains, that they can suffer an injury and do well. That is true, but the injuries are real and they have consequences. And if we think of it in terms of plasticity, yes, children have plasticity. But if we think in terms of a developmental curve, children will get derailed off a developmental curve. And our theory, at least, is that the longer we let these brain injuries fester, the more severe they become, the less likelihood there is of retaining or regaining a developmental curve. So we still think of brain injuries as being time sensitive. We are very focused on the idea that the metabolic demands of the brain are very high and that they may be compromised in the setting of acute illness. And this is a vague statement by design. This is a concept that I'd like to come back to over and over again. And basically, most of how we approach these patients is with the idea that the various components of metabolism are addressed through our approach to neurocritical care. So what are the goals then? In the immediate setting, our goal is to provide rapid treatment and diagnosis in parallel. So we don't just treat blindly and we don't try to diagnose something and then treat based on the diagnosis. We try to treat things that we can, and we also try to form a formulated diagnosis. And what you'll find, I think, if you do this for long enough, is that we're often the primary diagnosticians in the setting of the critical illness. While people are trying to stabilize the patient, our brains naturally tend towards trying to figure out what's going on. And that can be very helpful in the acute setting. So we want to make sure that the ongoing brain injury is limited. Like we said, time is brain. We want to make sure that the healthy brain tissue that remains is preserved, and that in parallel with that, any brain tissue that's at risk for further injury is that injury is minimized. And then we want to take diagnosis-specific decisions as possible. So if the child comes in with an underlying diagnosis, that's helpful. We will think about that and try to use that to our advantage. And if they do not, then we will try to think of red herrings or red flags, as in things that are concerning or things that are diagnostic in the presentation of the child to help us guide their management. And then I think one of the main things we bring to the table is trending a neurologic exam, and we'll talk about how we can do that. For some of these patients, the neurologic exam is very minimal, but we want to make sure that we're trending the neurologic exam over time, and that if there are any changes, that we react to them rapidly. Okay, so I'm just going to give a couple of case scenarios to guide us through this. The first case is a 10-year-old previously healthy female who arrives in the emergency room 30 minutes after collapsing while playing outside. There was no trauma. Upon examination, she's actually awake now and she's tired, but she has a dense left hemiparesis. Your team suspects a right MCA stroke and initiates the appropriate imaging plans and consultations. Now, before I go further, I'm just going to point out that each one of the diseases that we could discuss here could be their own lecture, and I'm sure you're going to get discussions on all of these things. And if not, then we should work on doing that, like having specific stroke lectures and status epilepticus and things like this. I'm going to try to distill the common principles from all of these into neurocritical care as a field. So in this patient, we already think that they have an MCA stroke, and we're going to initiate a rapid response to that. And I'll talk a little bit about that too. So in the time between the child coming to the emergency room and them getting an image, which is going to be one of the first steps to diagnose the stroke, there's still time that equals brain. And we use that time to our advantage to establish protective parameters for all children, whether it's for a child with stroke, child with sepsis, child with traumatic brain injury. We're always trying to think about specific neuroprotective measures. And my goal here is to kind of lay out for you how we think about it, and that it is in fact different for every child. There's no universal neuroprotective measure. Each condition is going to have a more similar set of parameters, and I will talk you through this. So really, neuroprotection is the procedures and parameters that are designed to optimize health of any brain tissue at injury risk. So whether that's tissue that is already vulnerable due to transient hypoxemia, or whether that's brain tissue that's currently healthy but is at risk of underperfusion or herniation or cerebral edema, all of those different mechanisms fall under the rubric of neuroprotection, and we're trying to protect that healthy tissue. So what we're going to try to do is deliver metabolic substrate. We're going to reduce metabolic demand. We're going to remove any offending agents that could be making the situation worse. And in some cases, we may even try to provide some metabolic support. So one of the key considerations here is blood flow optimization. And again, I will reiterate multiple times throughout this that everything I'm going to tell you is going to sound really obvious, but the key isn't that it's obvious. The key is to actually try and implement it in real time and rapidly. So blood flow optimization refers to cerebral perfusion pressure, and cerebral perfusion pressure refers to the pressure of blood flow through the brain. And the way you calculate that is take the mean arterial pressure and you subtract the intracranial pressure. Now, as many of you might recognize just from looking at this, intracranial pressure is not something that we typically know. We assume it and we try to pay attention to it, but we don't know an exact number. We can measure the MAP. And so what we try to do in a lot of these cases is optimize the MAP, the mean arterial pressure. And in cases where we think the intracranial pressure may be higher, we will push the MAP higher so that the difference is great enough to provide cerebral perfusion pressure. So this is an empiric treatment based on assumptions that we make about our clinical scenario. And this is a prime example of how the neurologist in the acute setting can keep this in the front of their brain, cerebral perfusion pressure, and look at the parameters of the patient and try to optimize it for that given scenario. So in the case of a stroke, for example, we don't anticipate that acutely, we do not anticipate that acutely in an ischemic stroke, the intracranial pressure will go up very much. It should stay around somewhere around normal initially. That may change as cerebral edema evolves, but initially we wouldn't expect it to. So what we're going to target is a mean arterial pressure above normal. We don't need to push it higher. We just don't want them to become hypotensive because we want to support blood flow to the brain during this time. Similarly, we're going to think about using IV fluids to help us with that. So we typically provide extra IV fluids in the setting of an ischemic stroke. But the point I'm trying to make here is that in the case of, say, a hemorrhage, an intracranial hemorrhage, you may not want to increase intracranial pressure, and you may not want to give extra fluids. So you want to think about it within the context. There are some patients, like patients that are septic, who are going to come in and are going to be hypotense. And so in their case, the cerebral perfusion pressure will drop, and you will definitely be already giving IV fluids as part of the sepsis management, but paying attention to the sort of goal-directed therapies. Now, as I've mentioned earlier, and I'll mention again, these are theoretical constructs. These are things that you should be thinking about in real time, but the data about whether to target cerebral perfusion pressure, whether to target mean arterial pressure goals, those are not evident from pediatric literature. So what we do is the best that we can. And I will later on give you some ideas about how we might be able to actually measure things like cerebral perfusion pressure non-invasively. And then the last thing we do is this head of the bed positioning, which is a classic neurosurgery tool to alter blood flow. It's the use of gravity, essentially. So as you raise the head of the bed, gravity will help blood drain from the brain. And that, in theory, will help if there's increased intracranial pressure secondary to cerebral edema or a venous thrombus or something like this. So initially, we actually lay the head of the bed flat in a stroke, for example, to try to reduce the effect of gravity on blood flow so that perfusion to the brain is optimized. But as we are worried about intracranial pressure, we'll raise the head of the bed. Now, this is like a classic adult teaching thing, and it's a surgery thing that everybody knows. All these sort of indicators here, including cerebral perfusion pressure, intracranial pressure, cerebrospinal fluid volume going down. All of these things are known and more or less validated. But I just want to point out that this elevated height that induces gravity-induced drainage is not very large in a child. And so the smaller the child, the less that delta, that height is going to make a difference. So while I think it's important, I think people can often spend a long time debating these things. I think if there's a question, like let's say somebody has a venous thrombus and a hemorrhage, and they're not sure what to do, I think in the absence of evidence of increased intracranial pressure, it's hard to leave that head of the bed straight up. And I think if somebody develops symptoms, you just lay the head of the bed flat again. But these are things that, in principle, you would use the head of the bed to help guide management of intracranial pressure. And if it helps you, then it helps you. And if it doesn't, I don't think you need to be too hung up on it. And a lot of the times your surgical colleagues are going to dictate what they want anyway. Okay, we talked a little bit about using IV fluids, but I want to speak a little bit more about how the use of fluids and electrolytes can be helpful in these patients. So as I mentioned, acutely in a stroke, as in case 1, you aren't going to be concerned so much about the risk of edema, but you are going to be concerned about the evolution of edema in the injured brain area. So particularly for larger strokes, there will be cerebral edema that evolves over time. There are other things like diabetic ketoacidosis, DKA, where edema is going to be a concern right from the beginning. And there are other conditions where you may not think about cerebral edema at all. Similarly, you may have other conditions that increase intracranial pressure that are not edematous in nature, like a venous thrombus. And if that's the case, then using fluids and electrolytes may not be your best management tool. But all of this is to say that we have to consider osmolarity. So most of us learned the osmolarity equation for serum that includes these variables here, sodium, glucose, and BUN. But the real reason I'm pointing this out to you is just to know that we know that all of these are osmoles that will contribute to the equation. But if you're going to try and use osmolarity in acute setting, so right away off the bat, you want to try to reduce cerebral edema, then what we're going to target is sodium. This is why people use 3% sodium in the acute setting. It's also why we get regular sodium checks on patients for whom we're worried about their evolution of cerebral edema. And sodium is a phenomenal osmole to try to help reduce the edema in the tissue by drawing fluid into the intravascular space when you increase the osmolarity. We also can talk about glucose as an osmole, but as you can see here, the glucose number is divided by 18. So each unit of glucose increase isn't going to provide the same kind of impact on the osmolarity. On the other hand, glucose can have negative consequences, both positive and negative consequences. It's a very important energy substrate, and hypoglycemia can be a massively negative impact. Many people have looked actually in the adult literature at what the optimal glucose range is for patients that are acutely ill. And there's a whole host of reasons for why one might consider glucose as a parameter to watch carefully. I think the easiest way to think about this is that if you're hypoglycemic, that's not good. And if you're hyperglycemic, that can come with infection risk and other secondary organ injuries. So there had been a movement at one time for very, very strict glucose control. 80 to 110 was what people would say. And studies that looked at this started to realize that in the interest of meeting that sort of tight glucose control, one of the things that started happening was people were so this is work from 2012 that was sort of a massive review for critical care literature. And what they basically suggested was if you have tight, the left side of this graph favors intensive glucose control and the right side favors sort of more moderate control. And if you can look at this meta-analysis, all of these studies essentially show some potential benefit, although most of them cross this sort of like not the midline, so that they're not necessarily better. But what these kinds of studies were arguing in aggregate, some years ago, was that if you have intensive glucose control, it's going to improve neurologic outcomes. That's what these are showing. However, what it also showed overwhelmingly was that hypoglycemia and adverse events occur that are not infrequent. So while the neurologic outcomes might be a little bit better with this tight control, looser control was clearly better for other adverse events. So the takeaway message that we have is it's a very rare situation where we're going to ask somebody to give, say, insulin to lower glucose. Their glucose would have to persistently be high. We're often going to let the glucose drift into the 200s, even higher. Now, again, if you take into account underlying diagnoses, that may not be the correct solution. But for most patients, if they have a transient elevation in glucose, especially in children, we're not going to go ahead and treat it. We're going to sort of monitor it. But we're going to monitor it closely, just like we monitor the sodium. And initially, at least, we'll probably check every 4 hours. So this kind of work, again, like I said, is not present in children, so we're extrapolating from the adult world. And similarly, I think we do the same kind of thing with reducing metabolic demand. So there are many different kinds of metabolic demand. This is a broad term, but things that we might think about are fevers can raise metabolic demand. Seizures will definitely raise metabolic demand. Autonomic dysfunction, where you have diaphoresis, or you have shivering, or you have dystonic movements. All of these things can raise metabolic demand. And these things may not happen right away. So they might happen, 6 to 8 hours or a day or two after the child is admitted to the ICU. And this again speaks to our continued involvement. So even though we're acutely present, we're also following in the subacute phase as well. And one thing you could argue is like, oh, well, you should just address all of these things and try to reduce them, treat the seizures, treat the autonomic dysfunction with a benzodiazepine, reduce the fevers. But the problem is that sometimes these fevers are not directly responsive to medication management. And so people will try to cool patients. And as you are all aware, there's been a lot of literature on cooling in different scenarios, even without fevers. And unfortunately, hypothermia can negatively impact cerebral blood flow. So if you just go back to one of the principles we talked about a few minutes ago, we don't want to reduce cerebral blood flow in most of these cases. So we want to optimize cerebral blood flow while reducing metabolic demand. And in some cases, hypothermia may be the right solution. What I'm going to show you here is some interesting work that was done to look at all different kinds of critical illness, neurocritical illness. So this is ischemic stroke, all stroke, TBI, and stroke with TBI and traumatic brain injury. And what this is showing is that these dots are studies that, so again, this is another meta-analysis. These dots are studies that are showing that mortality was better when you had normothermia as opposed to allowing for fever. So they're not talking about cooling, they're just talking about normothermia. And I think this is an important distinction. When we talk about temperature management, we're not always talking about hypothermia. Sometimes we're just talking about avoiding fevers or treating fevers aggressively. And even that small difference can be favored in terms of mortality. And it's not something I think of as a neurologic concern. Like when you're in the ICU and there's a child that has a fever, that may not be something you're thinking about. But clearly this indicates that for people with brain injuries, normothermia is beneficial over having a fever. Again, not necessarily rocket science, but the data supports it. And I would highly recommend that we do this very aggressively. I would highly recommend that any child coming in with a brain injury, the goal should be normothermia. And it's something that if they're not paying attention, the primary providers, to repeat over and over again, that this is something that actually does have some beneficial outcome related to it. Not just, and this is just one figure. There's a whole bunch of other figures in this paper that you can go and review, but even just for mortality, there's a benefit. And then along with these same lines, you can imagine that there's sort of like a reciprocal impact of the underlying diagnosis with the critical illness. So let's say a child has an electrolyte derangement, that could trigger seizures. And if they have an underlying seizure disorder, that can be quite catastrophic. They could end up in status epilepticus. And similarly, you can have a fever that triggers a neurologic decompensation like we're showing here. And if they have an underlying metabolic condition, for example, like a mitochondrial disease, which Dr. Sharma mentioned, I look at, it can be catastrophic and they can fall off very quickly. So I think being aware of metabolic demand in these children, particularly ones that can develop seizures or autonomic dysfunction very easily, is important, and trying to minimize that metabolic demand is very helpful. And one way we go about doing this is by using sedation and neuromuscular blockade to reduce metabolic demand. So we're going to go into what we can do in these situations next, but you can use sedation and you can use neuromuscular blockade. But one of the values of being a neurocritical care provider is that when you do those things and you lose your neurologic exam, you can then use the limited neurologic exam that's remaining and other non-invasive neuromonitoring tools to follow these patients very closely and determine whether you've made a difference or whether some further complication has occurred when the patient doesn't have an exam. So we'll talk about that, but I just want to make it clear that if a patient is shivering like crazy, you can use a sedating medication or something like dexmedetomidine to reduce that shivering, to reduce metabolic demand, but then monitoring that patient becomes more complicated and your involvement becomes more critical. So the last thing I'll just go over with the neuroprotection is to remove offending agents. So you really want to evaluate underlying conditions as much as possible. We talked a little bit about DKA or epilepsy, but also autoimmune conditions. You really want to see if there's something there that you can address acutely, whether it's an elevated glucose or medication non-compliance. In epilepsy, sometimes you can just load with some anticonvulsants, and that'll make a difference for neuroprotection. And then, infections are something that people, I think, outside of the United States who practice medicine in general think about a lot more. So this may be really obvious to you, but both CNS infections and systemic infections can impact brain health quite dramatically. So, this is sort of like a study that looked at septic patients who did not have a CNS infection or an underlying brain condition. And in this case, survivors, the percent of patients that survived that had a non-reactive EEG. So what they're doing here is basically monitoring patients with EEGs that have sepsis. And again, we'll talk about this in just a moment, but what they're showing here is that survivors typically had a reactive EEG, whereas non-survivors, about 50% of them did not. And what this tells you is that there's neurologic dysfunction that one could identify and that needs to be maybe you need to pay attention to it, maybe you don't, but the bottom line is these patients need to be treated aggressively for their underlying condition, which in this case is an infection that's not affecting the brain directly. And then there's neurotoxins that can be present. So I think people are familiar with ammonia in the setting of like a new onset metabolic dysfunction, like an ornithine tricarboxylate OTC deficiency. But there's other sort of offending agents that can become present in critical illness. And it's just important to try to, when you're sending labs and looking at like an acidosis, to try to think about those kinds of things and address them if possible. Toxins in particular that are ingested. Okay, so the last thing I'm going to talk about here for neuroprotection is oxygen. And oxygen is something that seems really obvious and important, and unfortunately just there's not a lot of data. So these are two equations that I think we all know. Cardiac output is the heart rate times the stroke volume, and the oxygen carrying capacity of blood, it involves the oxygen saturation, hemoglobin, a constant there, and then the partial pressure of oxygen. And these are critical care equations. People use these all the time in the ICU setting. And really all I want to say to you is that there are no good data or studies for parameters in these different neurologic conditions. But I think it's really important to remember that there's high variability, whether you have heart failure, whether you have something that could be affecting your respiratory status, there's going to be variability in these numbers. And so what we're really trying to target is normalcy. And we're not necessarily driving that, but paying attention to it can affect how you interpret your neurologic exam as well. Sorry, I did add this in the end. Okay, so this is something where there's no data to support the use of any kind of medication for neuroprotection. There are lots of studies that are out there, and one of the things that we all know is that once a tissue has become hypoxic or is in a hypoxic state, it's going to be vulnerable for mitochondrial dysfunction. These trials there's no trials that show any benefit, but there's lots of preclinical data that's supportive, and very few of these medications have a risk to the patient. Things like levocarnitine, methylene blue, and acetylcysteine are medications that are available and are used and don't cause any real side effects for patients. This is a preclinical study that was done in rats. If there's a traumatic brain injury and these mice are given carnitine, the area of the injury is less, and that is persistent on day 28. So this is the seventh day after injury and the 28th day after injury. And so we use this actually. We use carnitine in the acute traumatic brain injury setting or post-stroke. So for this patient, the 10-year-old female, here's exactly what we would do. We'd lay the head of the bed flat to promote blood flow in the acute phase. We'd give extra fluids. We'd avoid hypoglycemia. We'd target normonatremia with a higher upper acceptable limit. We'd enforce strict normothermia, and we would start levocarnitine. And this is what we do at Lurie. I call it the Lurie Special. If you ask my provider colleagues around the United States, you're going to find a lot of people don't use levocarnitine. I don't know that it's necessary, but this is something where we hope to report our data as time goes by on whether or not this has any impact, because doing a randomized clinical trial is just not going to be feasible. Okay, case 2. A 3-year-old male with intractable epilepsy and cerebral palsy is admitted with sepsis, develops disseminated intravascular coagulation. In the process of treating him, he is paralyzed and sedated pharmacologically. The ICU team is concerned about his neurologic status. They call you. So we're going to talk here more about neuromonitoring. So neuromonitoring is the procedures to analyze brain function, often in real time. It's anchored by the neurologic exam, which is unique in the ICU. And it's important because these are usually confounded by pharmacologic treatments or maybe absent altogether in the comatose patient. The bedside tools that are most helpful are ones that are actionable based on their valuable data. But I think it's important to recognize that taking the patients to somewhere to get an image or having to take them somewhere is really hard. So having bedside tools is really valuable. And in the United States, and I know across parts of India now, bringing an EEG machine into the ICU is feasible. And I think, as you'll see in a moment, it has a lot of value. So the exam may be limited, our physical exam. People always talk about the Glasgow Coma Scale, and it does help with acute decision-making for the trauma teams and for the ICU teams. But I like to think of it as being sort of the gateway to our neurologic exam, which then helps more with localization of injury and a prognostic trend. So really what we're trying to do is identify localized injuries and then detect acute changes as they occur. So this is a nice figure, I think, that separates out the Glasgow Coma Scale on the one hand from our more specific neurologic exams. And what you'll see here is we're looking very carefully at the eyes for pupillary size and light reflexes, for eye movements and eye position. And then we're also looking at brainstem responses like corneal reflexes, grimace, and cough. And these are things that we try to get every day on our patients and track them over time. You will see that that exam is really a critical part of what we do, but we try to supplement it with EEG monitoring. We choose who to EEG monitor, but honestly, at our institution, we monitor a lot of patients. There's a lot of reasons for that, and I'd be happy to discuss it offline, but I think every institution and every group has to make a decision about who to monitor. I'm going to try to give you some guidelines here. So one of the problems is terminology. So when when you see somebody having a convulsive seizure, it's a little bit easier to decide to treat them. But the terms subclinical, non-convulsive, and electrographic get used interchangeably. To me, subclinical means that there is no clinical correlate. Non-convulsive means that they may be having a behavioral arrest, subtle eye deviation, something that is detectable clinically, but not a convulsive seizure. And electrographic refers purely to whether or not you see something on EEG. And it can have a clinical correlate or it may not. So keeping that in mind, these adult studies are highly variable because they interchange these terms a lot. But they'll say that up to 50% of ICU admissions may have an abnormal EEG. And they could include periodic discharges and electrographic seizures. But whether or not treating them makes a difference is unknown. And so we don't really have a good sense of that. However, we do know in pediatrics that that there are lots and lots of patients that have seizures. And what I'll show you here is these studies, like this one's out of Sick Kids in Toronto, that was published in 2014 by Cecil Hahn's group. They show that if you get above, so the x-axis here is referring to how frequently these children are having seizures on EEG, and less than 20% per hour means 20% of an hour, so 12 minutes. And really the median patient in this is like 1.5 minutes. So it's really not 12 minutes, it's more like a few minutes. What this is showing is that the neurologic decline is predicted by the frequency of seizures on these EEGs. And so the more seizures you have, the more decline you'll experience. And this is shown here across all different kinds of admission criteria. So the red line is for acute brain injury, the blue line is for acute seizures, and the green line, which is overlaid almost directly with the acute seizures, is for systemic disease like sepsis. And in all these cases, if you get higher with your maximum hourly seizure burden, your neurologic decline, your risk of neurologic decline increases, suggesting that the more seizures you have, the worse you do. And again, this may not be news to any of you, but I think it's important to see the data as it's laid out. Another use of EEG is something we do here is for like hepatic encephalopathy. This is a very interesting area where children who have acute liver failure can progress very rapidly to need a transplant or have a very bad outcome otherwise. So they get monitored very closely and often get transferred to the ICU. We did a study here where we took we recruited patients based on based on a consult for hepatic encephalopathy, and we categorized them as to whether they survived or survived and did not have a liver transplant, or survived with a liver transplant or died. So the second group is they either had a liver transplant or they died. So this is arguably the more severe group. And what we saw was that in the survival group, so we did an EEG at the time of consult for all these patients, regardless of how sick they were. And what we showed was that if they had a normal EEG at the time of consult, they were much more likely to survive or not have a liver transplant. And this is similarly true for patients that had a low hepatic encephalopathy score. So you might say, well, maybe all these patients that died, maybe they were very encephalopathic at the time that they arrived. And in fact, that was not the case. So if you only look at our patients with a score less than 2, which is the majority, which almost all the patients in this survival group, it was all the patients, but in the group that passed away or had a transplant, 6 of the 8 patients, in fact, had a low hepatic encephalopathy score, indicating that even for children that appeared relatively well at the time of their admission, the EEG had some value in predicting whether or not they did poorly. Now, treating that EEG probably wouldn't have any impact, but it can help with the overall clinical picture of that patient and stratify their risk accordingly. We talk a lot about rapid imaging. As neurologists, we all love to look at brain pictures. But as I mentioned earlier, removing patients from the ICU comes with a lot of risk. There are some places, and we're not one of them, that have in-unit CT scanners. And then we favor doing rapid MRI scans if possible. So we tend to have a lot of situations where we want to do things like that. But we only really try to do it when it's going to change management. So if we're going to try and provide thrombolytic or intravascular therapy for a stroke, we'll talk about doing that. And really what I wanted you to take home from this is that we don't really view rapid imaging as a mainstay of neuromonitoring. It's something we do as needed, but we're often operating without a brain image for a lot of these children. The real reason I put it here is because I think anybody might ask, well, did you get an MRI? And the answer is no, we often do not. So there's a whole host of other tools that are very interesting that people may have heard of: transcranial Dopplers, near-infrared spectroscopy, pupillometry, and optic nerve sheath diameters, which is another ultrasound-based technique. All of these techniques have some value, and I'm just going to quickly go through them, but I want you to think of them as part of a larger multimodal analysis of a patient in the ICU. So what we're trying to do is use non-invasive tools that can help us make decisions in real time. So for example, with transcranial Doppler, there's lots of things that it's not useful for. I'm just going to put that out there right now. But this is an ultrasound-guided, non-invasive measure of blood flow that typically targets the MCA distribution on all the sort of distal branches of the MCA. And there are a number of measured and derived indices that you can get from this. It's complicated. You can get the measured variables that are here on the left, and then on the right, there's a whole bunch of derived variables, and there are courses to go and learn all this stuff. And in the adult world, they do a lot of this. But it's a very active area of research, and I think one of the things that's come out of this is that we still don't know when to use it and when not to. In particular, in pediatrics, we don't really know what baseline values look like. So using it to compare against itself in an individual patient has some value. Specifically, we use it as a measure of risk for vasospasm. This is the most well-known use of TCDs as far as I know. It's standard in the adult neurocritical care literature, And what they often show here is that the onset of vasospasm after a subarachnoid hemorrhage is correlated with a development of a stroke. And the idea is if you can identify the vasospasm, theoretically you could treat it, calcium channel blocker or something like this, to reduce the risk of stroke. Unfortunately, it really hasn't changed outcomes, but that may just be due to a lack of our ability to use it properly, because clearly, as you can see here, the time of onset of vasospasm and the time of onset of stroke, which is the light purple versus the darker purple, are correlated very tightly. So ideally, you know, this is a leading indicator, and we should be able to do it. Maybe more continuous monitoring would help us if we could really catch it right away. But typically we get these once a day, and in theory that once a day isn't enough to predict stroke well enough. But we do use it on every one of our patients that has a subarachnoid hemorrhage. And then we also use it in patients with a cerebral edema, but as I'll show you later, it's not necessarily a good tool for that. There are other things that you can use for that. And like I said, there's no standard data for TCDs. We do use it though. Optic nerve sheath diameters are something that that can expand as there's increased intracranial pressure. It'll push down along the optic nerve sheath and sort of push open the optic nerve sheath a little bit. Typically, a number of 4 millimeters has been used to measure this with an ultrasound. You can just take an ultrasound on the globe and you'll see the optic nerve sheath distally and you can measure it. We do this at the bedside. We found variable utility in it, but it is an excellent surrogate for raised ICP. And as a group from Chandigarh PGI, some of you may be on this call, published very recently, actually just last month, this sort of number of 4 millimeters, if you go above it, it correlates very well with an ICP above 20 in this data set. And in their paper, actually, they showed really nicely that the TCD indices that we looked at earlier don't correlate with increased intracranial pressure. We have used this, but we tend to avoid doing it regularly, as we find the clinical exam is more helpful for the questions that we're asking, but it may be useful in specific scenarios. And certainly if you have a question about intracranial pressure and you can't use a gold standard like intracranial invasive monitoring, this can be very helpful. And then last, I'll just talk about near-infrared spectroscopy. You know, infrared light passes through tissue, and in sort of a twist of fate, deoxyhemoglobin and hemoglobin have different absorption spectra. So you can use that difference by shining an infrared light and then collecting the refraction to tell you what percentage of your hemoglobin is deoxygenated. And this is sort of a surrogate measure. You can use it on any organ, and it's a surrogate measure for oxygen consumption. This is kind of a cool thing. They use it a lot in anesthesia, actually. And what they're showing here with these bilateral cerebral nears, the blue is on the right and the gray is on the left. These are placed right across the temples here. Is that when there was a hemorrhage in this patient, it was actually caught first on oxygen consumption in the brain. So because there was a lower intravascular volume, oxygen consumption went up on the brain, on the blood that was sluggishly flowing through the brain. And they were able to give back red blood cells and restore oxygen consumption in the brain. We use it as a way of tracking non-invasively when a patient is sedated and paralyzed oxygen consumption. We put on bilateral cerebral nears, and we're often looking for asymmetry. It has not been particularly useful in extreme scenarios, but it is useful, we find, in patients that are at risk for stroke. So if you have like ECMO, or if you have a ventricular assist device in the acute period, there's a risk for stroke, and we tend to put these on, and we have found in a couple of cases asymmetric nears. This is a continuous monitor, and we would look for a trend over time. Unfortunately, it hasn't changed management in any of our patients, which is why we haven't published this data, but eventually we do intend to show that data. And last but not least is the pupillometer. This is a classic tool that people use to sort of examine the pupil. I don't really know how useful it is for most people, but there is a lot of daily variation in examiners, so it allows for keeping a record, a nice record there. You can just shoot a little ultrasound picture of the pupil, and it shows its reactivity. And so maybe in places where there isn't a daily neurologic consult, this is something that could be useful for tracking a neurologic exam at the bedside. Also slow changes, you know, we tend to see reactive pupils, but if they react very slowly, sometimes that can be hard to notice. And then if there's somebody who has more specific autonomic dysfunction, this can be used, but we don't tend to use it that much. So in case 2, this 3-year-old neurologically complex child with sepsis and DIC who's intubated, sedated, and paralyzed, we would do robust neuromonitoring for this patient. So we would document the bedside neurologic exam at the time of admission. we would put on continuous EEG. We would do bilateral cerebral NIRS. We would evaluate for any developing asymmetry. And if we saw something on any of these measures, we would try to get a rapid MRI. And then, of course, if there was a new stroke due to the DIC, we would start transcranial Dopplers daily to try to look for vasospasm. So let's put this all together in the last few minutes we have here. We have protocols at our hospital that are specific to our hospital for stroke, status epilepticus, and metabolic disorders. And then we also have CICU and NICU specific plans. And I will just try to walk you through these I'm not going to walk you through the whole protocols. I just want you to see how we structure these. So for our suspected stroke algorithm, what we're really trying to do is identify patients for whom thrombolytic therapy or intravascular therapy can be used. So we want to identify children who had a last normal that was within a reasonable time frame. We want to get those children neuroprotected and imaged as rapidly as possible. And so this is an algorithm that's present for our hospital, and it applies to the entire hospital. So anywhere this child presents, whether it's in the emergency room or they're sitting on the general medicine floor and suddenly develop an acute neurologic deficit, we would go through this algorithm. And it's meant to funnel everybody into a rapid stroke treatment plan. And it involves our involvement almost right away. You're going to page us essentially the moment you are aware of this happening. The status epilepticus algorithm, again, applies to the entire hospital, is a little bit different. Here, what we're really focused on is acute management. We want to make sure that there's a nurse who's helping, who's able to go and get medications in real time. There's a bedside or primary nurse who's able to address this. And this is all based on the idea that rapid treatment of status epilepticus is more likely to stop it. And then lastly, the primary service provider is going to be the neurologist who's going to be at the bedside and is sort of addressing all these things. So these things are all happening in parallel based on our algorithm. And then lastly, we have this critical hyperammonemia pathway, which is like for a toxic metabolite that can cause brain injury if it's not caught early. And so the reason I'm showing you this is because this says consult neurology in a big star here, but everything else is happening on autopilot. So these are the kinds of protocols we try to design to try to have people involve us and try to protect the brain in real time. Lastly, we do things for neonatal stroke and therapeutic hypothermia for HIE. In the CICU, we do a lot of things related to ECMO and VAD, and these are all protocolized, but not hospital-wide. These are specific to the individual units. In the ED, we have an infantile spasms pathway to try to rapidly get them EEGs and treated, and also get them plugged in follow-up. I don't have time to go over the last thing I wanted to talk about today, which is neurocritical care follow-up. So I'll be happy to share that with you another time. But this is an emerging field where we see all of these patients in the neurology clinic later on, and they have a whole host of problems, but they're not really acute management issues. So I will stop here and take questions. Okay.
Thank you, Divakar. I think that was an excellent talk. And there are lots of questions. And this talk was attended not only by neurologists, but also pediatric residents and intensivists. There are quite a few intensivists in the attendees, so which is very good. And before we start the questions, I'll just ask Dr. Saha if he has any comments, any.
Thank you, Dr. Subhashini. Actually, Dr. Divakar has really made a brief overview as well as give insight into the every aspect of neurocritical care, starting from his definition, then his principles of management and monitoring, and especially he has given some insight about his management, especially the mitochondrial support, the use of levocarnitin, as well as the use of transcranial Doppler, and thereby identifying the vasospasm and using the calcium channel blocker. And he also given some information regarding how to monitoring, though they are very much mechanized, which may not be possible to extrapolate in this part of the world. But the few things that we can extrapolate, that is the use of levocarnitin. Probably in our part of the world, we are not using levocarnitin too much. And probably you are not also very much clearly monitoring the vasospasm by using transcranial Doppler. If you could remember all these few points, probably that will give a very better outcome of our critically ill children. And now may I request Divakar to address 12 questions asked by the participant audience.
Yes, happily I will do that.
Yes,
Thank you for summary.
I will be asking you them one by one.
Oh,
So
sure.
the first one is, do you have any experience treating COVID patients who need neuroprotection in the PICU?
So
It's
we
a
have
hot
had,
topic now. Yeah.
yeah, it is. And it's a very important topic, actually. And we have not had, as far as we know, any patients in our ICU that have had neurologic complications from COVID. We've had a lot of patients with COVID, and we've had patients with the MIS-C, the multisystem inflammatory disorder. For whatever reasons, we have not had neurologic complications. We've been consulted on a number of them, and we've done this kind of stuff. That's not to say that it's not happening. So I'm not sure why this is the case. Our volume's been high enough, and certainly on our adult colleagues in Northwestern Hospital, they are saying the same thing. They just haven't seen a lot. And so we're not sure what's different about our population or why that's the case. But what we have done is become part of a national consortium of neurocritical care doctors, and we've had a number of webinars about this. And I think all of the principles I just described to you are essentially what they're doing. The one thing that's a little bit different, I would say, is, and I realize that it's complicated, is there's a lot of focus on provider protection. Because for us, for example, if an acute stroke comes into the hospital, we never thought of that as being something that could be something where we need to protect ourselves. I mean, you get the flu, but it's not that common. These are viral disorders that, like VZV or something like that, where you don't really worry too much about it in the acute setting. But now if a patient comes in with an occult stroke, I think you have to worry about COVID, even if it hasn't been presented here, just because it's something that we don't know why these kids are having strokes. So, you have to protect the individual. And for the adults, I mean, they're really worried about it.
Absolutely, absolutely. Do you think we'd stop the screen sharing then, because we don't need your presentation now?
Yes, of course. Yeah. Sure. Just have to get back to it. What happened to my screen share here? There it is. Stop share. Okay.
Yeah, done. Okay. So the next question is cerebral perfusion pressure targeted or ICP targeted therapy is better?
It's a great question. Unfortunately, without better measurements of ICP, it's very hard to do that. If you have an invasive monitor because of neurosurgery, like a Bolt or something like that, then arguably that's the best you can do, because you can calculate your CPP and you can decide wherever your CPP is. But I don't think, I think what we would like to believe is that CPP is the best target, that maintaining an adequate CPP is how you optimize this. But without studies, it's going to be hard to know that that's true. And certainly there are people who disagree with me on this. But we always try to guess the CPP. That's like part of our rounds every day.
Exactly. This question is that in some cases of hypoxic injury, especially post CPR, it is seen that patients become hypertensive, and we attribute it to raised intracranial pressure. What level of BP should raise an alarm that we need to bring down the blood pressure, or what decides the level of BP that should be kept if invasive ICP monitoring is not done? Like we frequently don't do. So
yeah. So this is a great question, and I think we have struggled with this a lot because, especially after hypoxic injury, we would like for, in the acute setting, the brain to be perfused adequately. And so we're very hesitant to treat any kind of hypertension. We kind of let the brain auto-regulate. So this is something I didn't talk about today. It's sort of like the next level of neurocritical care. And it's really fascinating stuff. But auto-regulation is really a fundamental principle of blood flow in the brain. And most of what we're doing is just trying to support auto-regulation. But auto-regulation refers to when there's increased pressure in the brain, there's hypertension as a result of that to try to perfuse the brain. And that can break down. And if that breaks down, you get massive hypoperfusion and you can get severe brain injury secondary. So we'd be very hesitant to treat that kind of auto-regulatory hypertension. On the other hand, there are situations where the hypertension is actually an indicator of cerebral edema that needs to be treated. And so while we're not necessarily treating the hypertension in that case, we will be reacting to it with management of the driving force for that, which would be cerebral edema.
So it's not really, you're not giving antihypertensives in this situation.
No, I would avoid that. I would really avoid hypotension, and even bring somebody to normotension, maybe relatively hypotense for a patient that has an acute brain injury. Are there targets?
Yeah. So are there any targeted blood glucose levels for children with raised intracranial pressure?
No, there aren't. This is something that people have tried to stratify and look at in different ways. And particularly in children, we don't have good data on this, but everybody who's tried to target a blood glucose ends up finding that the few times that you have hypoglycemia in treating an elevated blood glucose, you end up with much worse neurologic outcomes. So the only time you really want to target blood glucose is if it's low. And if it's super, super high for a prolonged period of time, then you can use insulin in a controlled fashion. But I think if it's an acutely elevated glucose, then just targeting normal and high normal. So, we let our children go up to like 150, 180 regularly.
Okay. What is the current role of invasive ICP monitoring in children with raised ICP? Like, are you doing it, or which are the patients you do it in?
So we don't do a lot of invasive monitoring with for ICP. This is an institution-specific thing that happens here. This may change as time goes by. This is one of the reasons we put so much effort into the whole multimodal non-invasive monitoring thing, is to try to get a sense of what the impact of the intracerebral pressure is, whether we think it's elevated, if it's having a negative impact. But the history at Lurie Children's is essentially that invasive ICP monitoring has more negative outcomes than positive outcomes. That's a correlation, and I think that was probably related to who actually got those monitors and what their outcome is going to be like. But currently, we don't ask for invasive monitoring in these children, and we have, like I said, a whole other cerebral autoregulatory study and work group that's trying to figure out non-invasive ways of measuring ICP accurately.
And what are the specific neuroprotective measures you would use for patients with super-refractory status epilepticus, especially patients who've been on IV anesthetic agents for?
This is a really great question. So I think here, there's really not much you can do to improve those outcomes. All you can do is make them worse. So I think being really strict about, sodium, glucose, making sure that there's excellent oxygenation, that these patients don't have secondary issues, because a lot of these children develop infections or develop some kind of, bed ulcers that can get infected. They develop other sort of electrolyte wasting phenomena. They develop kidney or liver injuries. Just managing all of those in a supportive manner as best you can. There's really nothing specific, especially in this prolonged status epilepticus. When they come out of that, you really want that whatever brain tissue is is vulnerable to have optimal oxygen delivery, optimal blood flow, so that it can recover. And like I said, you can only really make things worse. You can't really make them better.
Yeah,
it's kind of a sad truth.
Difficult patients, yeah. There's a question that, do you use thiamine and B12 in acute encephalopathies? Is there any role of these vitamins?
Yeah, this is something that's sort of an active area of interest of mine. So just like at Lurie, we use levocarnitine. There are other places that refuse to use levocarnitine, but will use thiamine in certain situations. The level of evidence is the same. So it's going to come down to people's preference and what they think is safe and what they think is appropriate, maybe their experience with it. I'm very strongly of the opinion that thiamine has a lot of value with low risk. I don't know that we're going to be able to measure this in a randomized controlled trial because, again, thiamine is freely available. It's or relatively freely available, and no one's going to run that trial. And again, it's hard to get the high number of N. So I use thiamine for some of my patients. The reason I didn't put it in here is because it's not universal in our group. So I'm trying to represent how we do things here universally. But some people may have heard of this, the HAT therapy. This is hydrocortisone, acetylcysteine, and thiamine. And what they're essentially doing in a lot of ICUs around the United States now is adding this on to any patient that's septic. And the reason they're doing it is because there was a large retrospective trial. So there was 3 years where the group didn't do it, and then 3 years where they did it for every patient in their ICU, and their mortality went down by 50% with no other standardized intervention for sepsis alone, just adding these three things. So, and some places have replicated that using carnitine. So how that works, why that works, I don't know, but I think it supports the idea that vulnerable tissue, where there's mitochondrial dysfunction in particular, could benefit from metabolic support. And thiamine, I think, is great. B12, I think there's even less evidence, but I wouldn't be averse to using it. We actually have a kit on B12 right now. I'm not sure why.
good. So what is your experience in managing patients with paroxysmal autonomic instability with dystonia, PAID, in children with traumatic brain injury or HI post-infectious brain injury?
So we have to do that quite a bit. I wanted to share with you sort of a protocol that we have for managing those patients, where we kind of go through something systemically. What we found, and this is the challenge I think with these patients, is that it's very hard to predict who's going to develop it and who's going to have very severe forms of it. Children with, obviously, if you have basal ganglia injuries, you're going to have some kind of dystonia that might manifest. But I think in terms of the real, true sort of parasympathetic, sympathetic hyperarousal, paroxysmal sympathetic hyperarousal, you can have a really severe brain injury and have a mild version of it in the acute phase. You can have a mild brain injury and have it become worse as you get further along. And I don't know why that is. So what we try to do is really focus on thinking of this as a triggered phenomenon. So in the initial phases, in the first, say, 2 to 3 weeks after the injury, we use lots of benzodiazepines. We tend to add on gabapentin pretty quickly, and just try to calm down all of this hyperarousal. But we try to take those medications away, and what we find is our rehabilitation colleagues are very aggressive in removing sedating medication so that the children can participate in rehabilitation. And then they come back to clinic 3 months later and they say, you know, I'm having these swings in my heart rate, or I'm sweating a lot. And so then we kind of try to identify what are the triggers for those things, and try to remove triggers. It's a lot like headache management, actually, in a way, which, by the way, is also a major complication for a lot of these kids. And so we do diaries and we try to help the families identify what's triggering it. And sometimes it's just things like reflux that was not diagnosed previously. And these kids have G-tubes now. And that's something that, pretty much all my kids end up on some kind of PPI or something like that. So in terms of medication management, our mainstays are in the acute setting, are benzodiazepines and gabapentin. And then we have a number of other things we try, well, I'm not going to get into it right now, but we would try a lot of things like to address more symptomatic stuff in the longer term patients that are in the hospital. But our goal is to really get children off of it. And unless they have really severe paroxysmal sympathetic hyperarousal, we try not to have them on daily medications for it 2 to 3 months out from their injury. And when they do, we try to do it in concert with the rehabilitation doctors, who are really good at this, by the way. They would give a great talk on this.
So there's a question that if there's an external ventricular drainage, then can you monitor the intracranial pressure by use of a saline manometer?
Yes.
Would that be possible?
Yeah. So we've tried that. Our neurosurgery colleagues are not. This is a lot in collaboration with neurosurgery, and I've learned over time that different institutions have very different relationships. So we don't get to make that choice here. If there's an EVD, they get to decide, and they universally don't like to do it. But there have been specific instances where we've done it before, so it's possible, and we would be very open to having more invasive monitoring of the brain if our colleagues were willing to do that.
So there's another question that amongst hypertonic saline and mannitol, what do you prefer in teaching?
Hypertonic. Use hypertonic. So this is one of those really challenging things that happens where you use a whole bunch of hypertonic and you get to a certain point and then you can't really do much more. I think then you can try mannitol, but mannitol is really not going to do much for you. It's sort of like a one shot and you got it or you don't. So I think it's a last ditch effort for me, but when you're in the acute setting, push your sodiums higher. Your kidneys, most kids' kidneys can handle it just fine. And there's a lot of benefit to it. There's some people that are really worried about hyperchloremic states. And I confess, I don't really know the literature on it very well. When my ICU colleagues bring it up as a concern, I have to defer to them and say, listen, if we can't give more sodium chloride, then we can give mannitol. But we tend to use sodium very aggressively.
A lot of interest in your thiamine, and what is the dose people are asking that you would want to use?
Yeah. So we don't have a standardized dosing for thiamine. And I've used it in a very, I've used it very erratically. So I shouldn't have exposed myself here to say that I use it, because I get to make that decision on my own. And I don't have a standardized approach for it.
Okay.
If people have specific questions about specific instances, I'd be happy to talk about it. But what I've been using, there is a published, this HAT therapy thing is published for people that want to use it, but it's not published for kids. And so I can share what we do at Lurie separately, but it's not like validated. So I don't give recommendations.
Okay. So one question about monitoring. Do you follow a protocol of intermittent daily interruption of sedation and muscle relaxants for neurological assessment? Is it recommended?
No, this is a great question. And I think every institution is going to have to be different in this regard. We do not do that. And the reason we don't do it is because we have made the claim, whether it's valid or not, we've made the claim that our neuromonitoring is sufficient and won't add anything. We won't add anything by doing interruption, and that we may lose what we've captured for these patients if we interrupt their sedation and paralysis. So we've conceded that we're able to get as much information as we want without it, and that the delta of removing sedation and paralysis, while clearly beneficial in some ways, because you'll get a better exam, isn't enough to put the child at risk. And if they're going to raise, lift sedation or whatever, we get paged immediately so that we can come and examine the patient, but we don't ask for it on a scheduled basis.
Okay, so have you had situations where you have electrographic silence on the EEG but present brainstem reflexes? It's like,
oh man. Yes, we've had that situation. And let me just phrase that with the caveat that electrographic silence in the ICU is an incredibly challenging statement to make because there's so much interference from all of the different things that are there, correct? So, but, between neurologists and whatever ICU docs are out there, just plug your ears for a moment. Sometimes we know that it's silent, it's a really bad looking EEG and it's pretty bad, but we still have some brainstem reflexes. We deal with that on a case-by-case basis. We try our best to try to tie together the etiology for the brain injury, the evolution of the injury, and the evolution of the patient with what we're seeing. You can imagine a scenario where you have electrographic silence, but that the brainstem is somehow functioning enough. But then really the question becomes, can the patient breathe? And we as part of the brain death examination. I didn't go into brain death here because it's a very American concept, and I don't, and I didn't want to get into that, but we do test apnea. We do apnea tests for these patients, specifically for these patients, and we refuse to do EEGs again.
Yeah, I think same.
That's a really important thing, right? It's just no more EEGs.
Yes. So what about which are situations where you would use therapeutic hypothermia? Any specific indications, like would it be helpful in acute necrotizing encephalopathy, fires, or any particular situations? Because you said it can reduce blood flow, and it's a tool which has to be used, unlike newborn where we know, it has a defined role. What about older kids? Which are the kids you use it in?
So we have our groups, fires and Norse, this sort of spectrum of rapid onset status epilepticus, refractory status epilepticus. There's some literature to suggest that hypothermia has some value there. We don't use it. We stick with our principle of normal temperature regulation in these patients and try to do essentially everything else. And the reason for that is because I think all of us sort of live in perhaps it's a little bit of a bubble, but here we live in a bit of a world where we have seen that it ends up complicating the care of these patients quite a bit. So we cool patients to get them to normothermia, but we create a distinction between that and hypothermia. So there is not a specific scenario where we use hypothermia. However, patients that are on ECMO or that have had recent heart failure, their core temperature is controlled by their blood flow. So like for a VAD patient or for an ECMO patient. And so sometimes their core temperature is lower and we don't ask them to change that. So we're not saying don't do it. We're just saying we don't want you to impose it on a patient if it's going to complicate their care. And we don't have enough evidence to support using it as a regular therapy for anything. So at our institution, it's essentially not used.
There was one question, temperature control. Like if fever doesn't respond to antipyretics, would you recommend tepid sponging in these patients?
Sorry, would you recommend what now?
Tepid sponging. Sponging.
Yeah. So yeah, we do that kind of stuff. I mean, again, here we would actually cool those patients to normothermia. with a cooling tool. So that's actually when we use the Arctic Sun cooling machine the most, is for refractory fever to get them down into normothermic range. But yeah, we would highly recommend doing whatever you can to get their temperature down. That doesn't injure the patient further.
So one question is that would the management of raised intracranial pressure differ if it's a traumatic versus a non-traumatic brain injury?
Yes. So yes, the etiology of the injury will impact how you approach intracranial pressure management. Traumatic brain injuries, more often than not, like severe traumatic brain injuries, are going to end up being surgical management. Non-traumatic brain injuries, especially like if we're talking about like DKA or something like that, that's not even a brain injury, it's just a massive risk of cerebral edema. That's going to be pure medical management. And in that case, we're probably not going to worry about intracranial monitoring. We're just going to go with osmotic management for those patients. The in-between state, the ones with the MCA strokes, we have our share of patients that end up with a craniotomy for decompression. But I think generally speaking, traumatic brain injury ends up having, especially severe trauma, ends up having a lot of surgical complications associated with it. Mild traumatic brain injury, we just don't see in our ICU. So they end up going to the floor and getting managed there. And that's a gap in care. I do believe that. There's other groups like in Oregon and LA that are really, really good with all traumatic brain injury, and they see all of them in clinic. And I think there's more commonalities than we're willing to admit, but those are mostly follow-up related, not acute management related.
Okay. So I think we had lots of questions, and it's been such an excellent talk with so much great discussion. Sir, Dr. Saha said you want to say something before we wind up?
Yeah, I already talked. Thanks to everybody for joining the webinar. Probably all of you will get some benefit from this lecture. Thank you, Dr. Divakar and Dr. Subhashini, for this joint meeting and presenting such a nice topic for today's webinar. Thank you all.
Thank you, everybody.
Thank you, Divakar. That was an excellent talk. We all learned so much, and I think both in terms of monitoring as well as therapeutics and the general systemic care of the patient. And we hope to see you more. I think a lot of topics that people are interested. I can see that raised intracranial pressure itself merits a talk, probably.
Absolutely. We can make it happen.
This is something we should have it, before your mitochondrial
oh yeah
talk is perhaps. So
that can wait.
Yes, that can wait. Yeah. So thanks again, and thanks to all the participants for this very active participation. We've never had so many questions, I think, before any session. Lots of this generates a lot of debate, and thank you, Dr. Saha sir, for participating with us, and thanks to all the attendees. And we will see you next Wednesday with another topic. Its next topic is basics of MRS for pediatric neurologists. So we hope to see you all again. Okay.
Thank you.
So good night. Good night.
Good night. Bye.
Bye, Divakar. Bye, sir.
Bye, sir.